to join, but I'll go ahead and start the introduction in the meantime. So just so you're aware, this is the Fellows Online Education lecture series put together by the AMSSM, specifically the Fellows Online Education Subcommittee, the Education Committee, which is part of the Education Committee, and the Fellowship Committee. Tonight, we're extremely lucky to have our speaker, Dr. John Wilckens. Dr. Wilckens is an associate professor at Johns Hopkins. He is the chief of the sports medicine division, which encompasses the orthopedic surgeons as well as the primary care sports medicine team. He did his medical school at George Washington. He did his residency at the Naval Hospital in San Diego. And then he did a sports medicine fellowship at Methodist Sports Medicine Center in Indianapolis, where he worked with the Indianapolis Colts as well as Purdue University. He's currently the team doctor for Navy Athletics, the Naval Academy. In the past, he has worked as the team physician for the Baltimore Orioles, the U.S. Marine Corps boxing team, and continues to work with many high school teams in the Baltimore area. I know I'm very fortunate to have his mentorship and guidance, and he's really been instrumental in making high school sports safe for our youth in Baltimore, serving on the state medical advisory board, as well as ensuring access to sports medicine care. And he is definitely one who can speak about masters athletes. He has been working in the Baltimore area for many years and has seen athletes at a young age. And as they've aged and wanted to continue to make athletics part of their daily life and their routine, they have stuck with him as their physician, having him guide him in order to take care of their injuries and participate safely in sports. Next week, please join us again. We have Dr. Todd Shatinsky speaking about foot and ankle fractures, and then that will be moderated by Michael Beasley. So that's Wednesday, April 2nd at the same time, 8:30 Eastern time. And really the goals of this online educational series is to be an adjunct to the fellows' own education that they're getting within their fellowship program. This does give fellows direct access to more educational experiences, hearing from AMSSM members as well as invited experts in the field. And the goal is to really help with preparation for the CAQ exam. So we do ask that you keep your microphones muted, and you can ask any questions you want in the chat function. If it's very relevant to what Dr. Wilckens is discussing at that time, I can chime in and ask him the question. Otherwise, we will save the questions for the end. And then we do ask that you fill out the evaluation after the lecture. This really helps guide us as far as what lectures you want to hear in the future, and how this lecture went, and what recommendations you have. And this is another way for you to let us know what lectures would be helpful for you to hear in the future. So if you go on to the AMSSM website, you can actually put in topics that you want to hear. You can put in speakers that maybe you've heard at your own program and who are excellent speakers. And you can make these recommendations to us. We receive it, and then we can hopefully line this up for future talks. And really the ultimate goal of this, we want to make you excellent sports medicine physicians, but this is really geared towards your CAQ preparation. So you can also use this QR code for any further suggestions that you have. All right. And then I will let Dr. Wilckens take over and share his screen to learn about the Masters athletes.
Well, Andy and Alexis, thank you for the invitation and the kind words. The original ask was to talk about the Masters athlete, and I've had an opportunity in my 40 years of practice of meeting maybe a handful of those master athletes, and actually they're they're more inspiring and educational than any other people I meet, because here are people that are continuing competing at a national level well into their 70s, 80s, and even 90s. And you won't see many of them in your career. So I took the prerogative to talk about the senior athlete, and at least an orthopedic perspective, because many of you, after you finish your training, will be going to sports practices or orthopedic practices, and you will see a lot of older people in your practice. Not only are they hurt, but they're actually trying to get active. And it's important for us to understand what they're trying to do and understand the perspective. And so I was going to share my perspective. And every day I probably see 30% of my patients are over the age of 55, 60. And half of them are extremely active, still playing pickleball, still playing ice hockey, still running. So this is going to be the focus of our talk today. Okay.
Okay. Yep.
These are my disclosures, nothing relevant to our discussion tonight. The objectives, we're going to identify the value of sport and exercise for the aging athlete. I'll talk a little bit about prescription and guidelines for the senior athlete. Then we're going to talk a little bit specifically about musculoskeletal injuries in the older patient, and then treatment thoughts of specific injuries in the older athlete. Like any athlete, I think the older athlete probably more so needs a pre-participation evaluation, general health evaluation. Even though they may not be smokers now, that many of them have had a smoking history, they're old enough that they may have developed diabetes, type 2 diabetes. They all have a family history. And it's important when you talk to them to find out if they've had any exertional symptoms, as this is important to predict a cardiac event, and if there's any first degree relative that has had an MI. Because they've been they've been on the trail for a long time. Many of them had a musculoskeletal injury and or surgery, and those are important to understand before you start your exercise routine. 12-lead EKG, lab studies, and then a good musculoskeletal examination, particularly as it relates to their sport, neurologic examination, then imaging is indicated. Next, Alexis. Nutrition is important for all athletes and all those competing, but even so in the older athlete, I think this is even more important because they may have very fixed diets and they have not had any nutrition guidelines. Certainly a balanced diet is important. A lot of these older athletes are very dehydrated. So hydration is a big part of their discussion. But as we exercise, especially as we age, you need protein in our diets. And as we get older, we lose muscle mass. And as we try to exercise, we need more protein. So protein tends to be a focus in our discussion of diet in this patient population. So exercise is not just going out and running. I think this patient population, I include myself in that, we used to run to get into shape. We used to run to lose weight. We used to run to get in shape. And now I think that it's more important that you get in shape to run, not that you run to get in shape. And aerobics is a big part of their exercise program, but there's many more things than just running. Resistance training, we've already alluded to that they need to build muscle and they need to build strength. So weight training or resistance training would be important. As we age, as many of you will find out in the next 20 or 30 years, you lose flexibility. And flexibility is very important when you're trying to compete and try to move across gravity. And finally, balance is one of the biggest concerns with our aging population is that they have falls, and that can lead to a catastrophic event. So aerobics is 3 to 5 days a week, 20 to 60 minutes a session. Begin with a very light intensity program. Many of these people have been runners their whole life, and they at age 50, 60, or 70, they come into your office because they can't run like they used to. Well, they can't run like they used to. Like I said, the master athlete, the ones that are genetically disposed to running well into their 80s, those people are very rare. So if running is important to that patient of yours and they want to continue running, you have to be able to modify their load a little bit. They may not be able to run every day, and that may be one of the problems that they are struggling with. The fortunate thing is that they have many low impact alternatives. There's many of these people are of means. They have access to a pool. They snowbird down into to the warm weather, so they have access to water and swim and water aerobics. Bicycle is a great tool for aerobic exercise. Stationary recumbent bike is particularly effective in this population. Elliptical trainers, there's a lot of them out there. Nordic Track was the first. This is a very, very effective way of elevating your heart rate and burning calories, and low impact on your lower extremity. And a lot of our senior athletes like to use their erg. Next, Alexis. And I'll keep coming back to this. I think I'll keep repeating this. As we age, we significantly lose muscle. If you actually examine these athletes in shorts, tank tops, you'll find that they have significant muscle atrophy of all muscle groups. So it's important that we attack these. We recommend resistance training 2 to 3 times a week. You can probably do it every day of the week if they have that time and energy, except I would do a different muscle group each time. You want to include all major muscle groups. And while there may be some crossover with your aerobic training, there's a lot of muscle groups that get neglected with aerobic trainings, and you certainly want to make sure that they're focused upon. You don't have to do a lot of weights, 2 to 4 sets, 80 to 20 reps. I think a very simple thing I try to explain to our aging athlete is you want to do high reps, low weights, and that's very safe. They're not going to tax their tendons. They're not going to lose control of the weight. Next. So resistance training has a lot of benefits for the older population. I know it's not very attractive to older women, and older men are probably embarrassed to be seen lifting weights, but I think it's a big part of their training program. It slows age-related muscle loss, and we find that losing strength as you get older makes it harder to navigate their retirement years. They can't travel. They have a hard time walking. They have a hard time doing things in the yard, gardening, shoveling. So strength training is very important, and it also helps them keep from falling. Other things that come from resistance training, which will help these patients as they get older, is increased metabolic rate, because that slows down as we age, improved insulin sensitivity, and increases bone mineral density. And this is particularly important in our older women. Next. Flexibility. We all get stiffer as we get older. Typically, I don't know when the magic point is, because we used to think younger kids are very flexible, but as we get older, we lose a lot of flexibility, and that can be a lot of dehydration in the joints, but the muscles shorten up. But you want to make this a big part of it. They need to allow some time in their treatment program, in their exercise program, to allow for flexibility training at least 3 days a week. And you can incorporate this into your strength routine. Those people that can lift properly can, in their strength routine, can actually do some stretching as part of their strength routine. Warm up is good with a light stretch, but I think there needs to be a deliberate focus post-exercise when the muscles are warm to improve flexibility. Next. And again, one of the catastrophic things that happen as our patient gets older is that they have these potential for falls, and that can represent a catastrophic event, whether it be a wrist fracture, it could be a hip fracture, and the trip to the ER, trip to OR, and those things will certainly interfere with their older lifestyle. So if you can improve their balance, it's important, and it doesn't have to be anything that is very foreign to them, but doing things like yoga, Pilates, dance, Tai Chi, these are very, very effective ways to give these senior athletes postural awareness and to do proper balance. So it also brings into the play that you need strength and flexibility. So all three of those play together. Next. Like every person that's going out to exercise, what we want to do, the purpose of exercise is actually to improve quality of life, improve their well-being, but there are risks of exercise. And these can be acute injury, whether it be a acute muscle injury, whether it be a hamstring pull or tendon rupture, or a fracture or a fall. Overuse injury is that you've used that muscle too much and have not allowed for recovery. Or more commonly in this population, we see acute on chronic injury. Particularly the bones are very susceptible to stress reactions. The osteopenic bone tends to resorb a little bit quicker and doesn't build up as quickly. And finally, tendinopathies is these tendons become very apoptic when they get older, and they're very prone to injury if you load them too quickly or too much. Next. So the biggest part of these aging athletes is that they have a lot of time on their hands. They're retired. They have an idea of what they want to do, but you may need to modify the volume, particularly as they start out. And if you diversify the program, it becomes more enjoyable and they're more likely to stick with it. They have to design a recovery program, time into that exercise prescription and stretching. Those are big things that you really need to focus on with this patient population. And what you really want to do is prevent acute injury and or overuse injury, because all of us have seen our athletes with a hamstring pull or a sprained ankle or whatever, and seems like it takes forever to get better. This is even more so with the older population. When they rupture a tendon, typically requires surgery. If they have a muscle strain, it takes a long time to recover. So it's very important that we try to prevent injuries in this older patient population. What we see as our patients get older is that a lot of them will start developing arthritis, and that could be of several different flavors. There's a genetic osteoarthritis, that is that they are predisposed just from their gene type, and they have family members that have arthritis. They've already had joint replacements. You have your metabolic disease, and a lot of these patients are trying to exercise because they're trying to combat their rheumatologic disease. Then we have what we call post-traumatic arthritis, and this is probably typically what you might see in your office, that someone who was an athlete early on in life has sustained a significant injury, and then they've overloaded that joint afterwards. So that's the post-traumatic. It usually usually there's been a significant joint injury, whether it be an ACL tear or shoulder dislocation. Then you add repetitive micro and macro trauma on top of that, and that can lead to post-traumatic arthritis. Post-traumatic arthritis in itself does not come from intense exercise. In fact, if you look at people that exercise, their risk for osteoarthritis is actually less than the general population. Next. For osteoarthritis, the thing that I really stress with these patients when you see them in your office is to obtain and maintain full joint range of motion. We find that as you get an arthritic joint, they get these osteophytes, they begin to form, and it kind of captures their motion. The more motion you can restore, the better they're going to feel, the more muscle strength they're going to be able to do. And to give you an example, knee extension, we try to make that symmetric to the opposite side. You can't get all your quadricep strength unless you get all your knee extension. And I tell our fellows and residents that knee extension is one of the vital signs I use on evaluating our knee. Then you want to assess limb and body alignment. And this can be both static and dynamic. The static alignment is just what you were born with. Some people will have bow-legged, some people knock-kneed, some people will have hip anteversion, some people have hip retroversion, some people have pronated feet. All these things if you think about a car that's out of alignment and you should start running that car, these alignment issues can be problematic, and you may have to correct some of those with some bracing or some inserts or whatever. The other is what I call dynamic alignment, and this is where I think our physical therapists are very helpful. When you get some weakness in your external rotators, you get some weakness in your posterior tib tendon, and your foot goes into pronation, and your hip internally rotates, you can abnormally load your kinetic chain. And by improving some proximal and distal muscle strength, you can improve your dynamic alignments. I would use the analogy again of a tire that's out of alignment. You want to make sure that the wheel is aligned. You got proper air in the tire before you run that car out. And strength training is the balance of kinetic chain and improves your dynamic alignment. So that's a big part of it. And physical therapists or trainers in the gym are very helpful in this matter. Next, Alexis. So now we're going to talk about some very specific shoulder things that come in with your senior athletes. And one of the most common things I see in my practice is pain with overhead activity. And these will come in with pain with racket sports, whether it be tennis or pickleball, or their pain with swimming. They may have an actual injury or they may not have an injury at all, just some overuse. And this is a large differential and includes in that a rotator cuff disease. And it's important to be able to ask a couple questions and be able to sort out that. Unfortunately, a lot of those things exist together, so you actually have to attack all of those. Next. So the spectrum of rotator cuff disease, I think of all of it, so like anterior knee pain is in the younger athlete, I think shoulder pain in the older athlete is something that's ubiquitous and you're going to see it quite a bit. You can have what they call physical impingement. As you raise your arm overhead, your rotator cuff actually draws your humeral head down and in to clear your subacromial space. And that bursa exists up there to help provide some of that glide pattern to it. And if that bursa gets inflamed, it's called bursitis. It can actually cause pain and also cause some thickening of the tissues up there. As that head comes up that and bangs on that coracoacromial ligament, attaches over the anterior acromion. We used to think there was a type 3 acromion, but actually what happens is we take care of these rotator cuff injuries. That CA ligament actually calcifies from the blunt trauma, the head coming up and banging on it all the time. So that acromial spur can cause some physical impingement. The other thing that doesn't get recognized as causing physical impingement in the shoulder is the AC joint. And all of us seen AC joints that are arthritic or osteolysis from lifting, and you feel a big bump on the outside of their AC joint. But I would have you imagine that bump might be just as big going down or south. And if you look at MRIs pretty carefully, you see some of these AC joints have these large spurs on the distal clavicle that actually impinge on the rotator cuff. If you look at the rotator cuff at either arthroscopy or open surgery, when you get that shoulder at 90 degrees abduction, when people start entering that pain range of motion, that greater tuberosity has already cleared the acromial space and is actually under the AC joint. So the AC joint does contribute a little bit to rotator cuff symptoms. In fact, the biggest failure, the most common cause of failure of rotator cuff surgery is not addressing AC joint issues. So that ends up being a very common thing that we always test for, check for, and ask about is AC joint symptoms as we do our rotator cuff surgery. Dynamic impingement doesn't mean you have a physical impingement, but what happens is that there's a misconstruction in the rotation of the shoulder. You have some cuff weakness, so as your arm goes overhead, the cuff doesn't pull the humeral head down, so that the muscles get banged up on the inferior aspect of the acromion. Also, you can have partial tears or inflammation of the rotator cuff, and this can be a partial thickness tear or a full thickness tear. And all that is a big part of creating symptoms of dynamic impingement. If you can improve cuff strength, we'll talk about rotator cuff protocols, you can actually improve those impingement symptoms. Next, Alexis. Imaging is important. X-rays, one can show you the AC joint arthritis, show the acromial spur. You can see if there's glenohumeral arthritis and see if the humeral head's high riding. MRI is another way to look at the soft tissues about the shoulder, but you guys are all very well versed with the utility of using ultrasound to look at the shoulder and the soft tissues. Physical therapy has several goals to it. One is to improve range of motion. If you have a stiff shoulder, it tends to be a painful shoulder, and it can improve shoulder kinematics. If you look at the shoulder as it goes overhead, if you look at the shoulder from the back, again in a tank top or in the gentleman with their shirt off, you'll see that medial border of the scapula come elevating off posteriorly, and that's what we call scapular dyskinesis. What I don't want you to focus is so much on the posterior border of that scapula, but actually remember what's on the anterior aspect of that acromion. It's your acromion process. And so as your shoulder elevates and rotates, that acromion actually closes down. You actually close off the subacromial space. And you can prove this to yourself the next time you see this big scapula coming off the chest wall. Hold it down with your hands, and the patients will have a much easier time clearing their subacromial space and their greater tuberosity. And so that's important. Just getting all the cylinders of fire at the proper time. Then finally improving strength. And sometimes strength training is very painful at the beginning. They can do some isometric exercises. You don't need a lot of heavy exercise equipment like 2 or 3, 4 pound dumbbells or even just bands. Next. Injections are very common in this population because they want to be active and their shoulder hurts. Subacromial injections, of volume injections, usually about 10 cc's, and you want to blow up that whole subacromial space and bathe the rotator cuff and the bursa. AC joint is another place you can, if you're not really sure where that pain's coming from, some of these injections are both therapeutic and diagnostic. Glenohumeral injection we don't use very commonly. With the two settings that we do use it, and you'll see this in again the active athlete, because one, they will get adhesive capsulitis and they lose shoulder motion. And doing a glenohumeral injection with a Kenalog, but there's a lot of research to support that will reduce the natural history of the adhesive capsulitis. Also, glenohumeral arthritis, a judicious cortisone injection is very helpful there. And finally, the biceps tendon can be very, very painful. And again, you guys can light this up with your ultrasound, but it's also important to recognize that that's usually travels in company with rotator cuff disease, but there are some isolated biceps tendon sheath irritations, particularly someone who's been doing a lot of bench work or curling and stuff like that can get inflamed tendon sheath. For the injections, certainly you probably all trained to use ultrasound, but it's very simple to target these areas with just knowing the landmarks and be able to direct your needle that way. Next. So the pain differential is pretty significant. You have, in addition to rotator cuff disease, you have adhesive capsulitis. We see a fair amount of this these in the older patient population. These people are not very happy. They tend to be very active, but they're trapped by their shoulder. We typically treat this thing with conservative treatment, with anti-inflammatories and physical therapy. But we've been using glenohumeral injections, and that's been very helpful. AC joint arthritis. Again, I think this is very amenable to an injection. Long head of your biceps tendonitis, I've already mentioned, usually travels with rotator cuff disease. Glenohumeral arthritis. Calcific tendonitis is a injury we don't see very often, but when you see it, it can be very, very impressive in the amount of pain it provides. I mean, the subacromial space can be very swollen and actually sometimes can be red and inflamed. These respond very nicely to cortisone injection and/or some physical therapy. What you'll find in these patients that come in, you'll find yourself confused a little bit because they actually have more than one pain generator. And if you get an MRI, it's very that MRI will point out they actually have some pathology in all those areas. Because this is an older patient population, you certainly don't want to forget that they may be cancer survivors. So if they are, you certainly want to at least keep in your differential that they could have metastatic bone disease, and you certainly don't want to miss that. Next. Shoulder dislocations. While these are pretty hard to manage on your younger athletes, and all of them end up in surgery, and they have long rehab. These can pretty much be treated conservatively in our older population. Though probably the one CAQ question here that you probably should be aware of is that over the age of 40, if there's an acute shoulder dislocation, 50% of those are accompanied with a rotator cuff tear. So if a shoulder's dislocated from a fall in your older athlete and you reduce it, in addition to do a good neurologic exam, you want to just check the rotator cuff. Also, it's not uncommon to have a greater tuberosity fracture. So a lot of our younger patients, we tend to kind of pop the shoulder in, let them run off and do whatever. But in these older patients, they may have a greater tuberosity fracture. Most can be treated conservatively. Some need to be monitored because they can cause impingement, as that greater tuberosity can impinge as you go overhead. And finally, some actually need to be fixed. Next. Elbow injuries, typically we see in this patient population, short of the big trauma where they fall off their scooter and dislocate their elbow or break their distal humerus. We see very commonly lateral epicondylitis or tennis elbow, medial epicondylitis or golfer's elbow. We have a couple of our super athletes that have what they call country club elbow. They got medial and lateral epicondylitis. Though we do see it with tennis players and golfers, most of it usually has to do with their computer work and using their mouse at their desk space. Most of these we treat with rest and bracing, but most respond PT, and very seldom, very not uncommon, we can use an injection to get them through the acute phase, and very rarely do we ever need surgery. The one thing I've seen more and more in my patient population is distal biceps tendon tears. And if you read your textbooks, or there's going to be talking about an acute complete distal tendon. And this is someone who lifts something heavy, loses control. If they have a canoe overhead and the wind blows it and they lose control of the canoe, they drop a refrigerator, come down the stairs. And the distal biceps inserts on the radial tuberosity, bicipital tuberosity and proximal radius will pop off, and they get this reverse Popeye sign. You got a lot of swelling. You see this funny looking upper arm. And those are easy to diagnose. The hook test is very classically the test of choice. But if you actually put the arms in front of you and have them supinate and pronate the forearm, you can actually see the biceps move up and down. If it doesn't move, the tendon's torn. I see probably 5 partial tears to 1 acute tear now. What these are, the people go to the gym and overuse or done something stupid in the gym, which is not uncommon. And they get a partial injury. And what happens is they have pain with active supination, they have pain with elbow flexion. And if you do the hook test and you do the supination test, the biceps looks normal. But if you actually palpate the bicipital tuberosity, is very painful. And if you get an MRI, you actually see that there may be a partial tear where part of the tendon's off, or it's just elevated off 1 or 2 millimeters, and you get the lacertus fibrosis that keeps it from migrating up. So those tend to be pretty problematic. We always try to give them a course of conservative treatment because there's no urgency to fixing that. But I found very few of them tolerate conservative treatment, and a lot of those go on to be fixed. Next. Knee pain, pretty important. I think a lot of that's probably the most common thing I do see in my practice is knee pain in this patient population. And typically, it's you want to know if they've had an acute injury and a remote injury. And sometimes we'll have somebody who's had a former ACL injury or some type of ligament injury. Now they have a new injury and they've torn the meniscus. I want to find out if they've had previous surgery and certainly family history. If they have a strong family history for arthritis, it certainly helps frame your treatment algorithm. Again, try to get them in shorts. You want to look at their overall alignment. Are they knock-kneed or bow-legged? Are they internally rotated, externally rotated? You want to check for effusion. And that usually represents probably some type of either an inflammatory reaction, mechanical irritation that causes the fluid, or something that's torn inside. Range of motion, we talked about before. You want to make sure they have full and symmetric extension to the other side. You want to do a good stability exam. This includes not only your Lockman test for ACL and posterior drawer for PCL, but medial and lateral or collateral ligaments at 0 and 30 degrees. But even looking at the patella, I think there's a lot of missed patella dislocations as these people were active younger and they've had a patellar instability episode and they never were athletic again. And now they want to get back into things because their knees hurt. And a lot of them will have a lateral tilted patella. They'll have not an apprehensive patella, but they certainly have increased excursion. And that can be a source of patellofemoral pain, and it can be something that you can address. And then you can do your strength testing and then your provocative tests like McMurray test. Imaging, I recommend getting standing images because this kind of reapproximates what you see when you're on the playing field or on the court. And this would be a PA and AP standing and a flex PA view, and then your lateral views, and then some type of axial view looking at the patellofemoral joint. Trying to find patellofemoral pathology on your traditional front back knee x-rays is not very good, but your axillaries will be very helpful. Next. Knee pain differential, again, just like the shoulder, probably a lot of these things exist together. They may have some unicompartment, bicompartment, tricompartment disease. They may have instability. It could be acute. It could be a chronic or acute on chronic. Again, don't forget the patellofemoral joint. Again, a meniscus injury is not uncommon. If you get an MRI, and anyone over the age of 55, very few people will not have a meniscus injury. So you have to be careful. Is that acute or chronic? And is that something that they've always had, or is this something new? And then the tendon injuries, you can get quad and patellar tendonitis. Again, just like our younger athlete, you get patellar tendonitis. You can get some quad tendonitis in the older athlete as they ramp up their activities too much. And finally, rupture. Typically, it's a fall, but usually they have a prodrome of some type of quad tendonitis. But if they fall, have a hyperflexion episode, they rupture the quad tendon. The older athlete typically will rupture the quad much more than the patellar tendon. Next, Alexis. So this is where I spend all my day talking about meniscus tears in the older athlete, and it's very controversial, and it takes a lot of time to sort through this because one, you want to help the person, but two, you don't want to give them any false hope, and you certainly want to. It's easy to say no, so you spend some time with them and try to figure out what their expectations are, what their limitations are. History and exam are very, very important. Get standing X-rays and an MRI is helpful. The good news is that 50% of these will respond to physical therapy, even including runners and people that are very active. It's probably a little less so in people that are in cutting, pivoting sports like pickleball, like soccer, like basketball. And whether you do surgery on these is you'll find orthopedic surgeons will be on both sides of the fence. There are some that will never operate on this, and then there are some that will or there's a meniscus tear, they get surgery. I think most insurance companies are asking that we've exhausted some type of physical therapy. You have to document some type of injection. You have to document some physical therapy. I find that if they have an effusion and mechanical symptoms, they are probably more likely to benefit from surgery than not. But you still want to frame expectations. Again, they already have some knee pathology inside the knee. You can't make it a normal knee, but you can certainly make it a better knee. The question comes up, by taking the meniscus out, are you accelerating arthritis? That's a good question. I've taken lots of meniscus out in young patients that were irreparable. And there's a nice study coming out of Indianapolis from my former fellow director, found that as long as you maintain full range of motion, which includes full active extension, you can lose a meniscus. You can have a condylar injury, and your risk for developing arthritis is not that high. However, if you have a meniscus tear and you lose joint range of motion, your risk for arthritis accelerates. So I think it's really, if you end up having to take that meniscus out, that patient has to be in physical therapy, has to get their extension back, and that's important. The thing you have to do is you have to frame the expectations. Sometimes people get tremendous relief from this and they go out and they just beat up their knees some more. And that whatever made that meniscus prone to tearing before is still prone to tearing. We take as little meniscus out as possible. So it's not uncommon. About 20% about 5% of my patients, 1 out of 20, will come back for a second meniscus surgery somewhere 5-10 years down the road. So, and it's not uncommon for these people to end up with a knee replacement 20 or 30 years down the road. But again, I'm not so sure that has to do with the surgery itself. It might have been from the injury initially or the reckless abandon. So, but it does happen. And they're going to ask you questions. Well, what's my risk for arthritis if you take part of my meniscus out? And I would say the answer is it's a little bit higher, but you can keep that number lower by maintaining fitness, maintaining your weight, and maintaining your range of motion. Next. ACL injuries. Next to adolescents, this older patient population sees the greatest increase in ACL injuries, and this is well documented. And what we find is that they've done extremely well with reconstruction. So this is a new patient population, and I would say probably half my ACL reconstructions now are over the age of 50, and I've operated on probably half a dozen that are over the age of 60. A lot of these are active patients, they are ski injuries or whatever. If you ask orthopedic surgeons how they would fix an ACL in an older patient population, the answer would probably be an allograft, because there's no donor site morbidity. There is easy to do. It's a lot quicker. If you look at allografts versus autografts in the young population, allografts have a 2 or 3 times increased rupture rate. And it's if you look at the older patient population over the age of 45, allograft has maybe a 2 or 3%, not 2 or 3 times, but 2 or 3% increased risk of tearing over an autograft. But autografts typically are all soft tissue, and they have to be fixed inside the tunnels with interference screws. And if you remember that these patients have osteopenic bone and soft bone, and as you drill the bone, you actually can feel it. You don't need, it's very soft bone. I have found that I've done a traditional bone tendon bone autograft with what they call cortical fixation. So the bone from the bone tendon bone autograft actually sits in the bone tunnel, and that actually heals. You're not relying. The healing is going to be the ultimate satisfaction of the construct. The cortical fixation is you actually take advantage of using the cortex, the strongest part of the bone, to fix the graft for early rehabilitation. So even though it's a little bit bigger surgery, this patient population has done very well. They do need to understand it's going to interfere with their social life a little bit. They're not going to be able to drive for a period of time. They're not going to be able to, do a lot of high impact loading for a couple of months. But most of those patients are pretty happy, and I've been. That's actually my graft of choice in this older patient population. Next. Fractures. I think obviously these fall, and it's a lot easier to fracture. But the fracture I'm thinking about here are more your stress fractures and insufficiency fractures. And sometimes that's a hard call to make in this population, because they may already be working on insufficiency fractures just from the osteopenia. Then you overload that bone. It's not even an overload. It's just an increased load, and they develop these stress reactions. Impaction fractures, I probably take care of one of these a month, or someone has had some type of impact injury. They fall down the stairs, not a big fall, but things that you would see like a bone bruise on an ACL injured young athlete. Those bone bruises are actually impaction fractures. They tend to be very painful, and as long as they're not big, you can usually treat those conservatively, but they require some assisted weight bearing for a period of time. And again, you don't want to rule out a pathologic fracture in this older patient population. Next. Injury trends. I think the number of athletes that are older is increasing, and the number of athletes in that age group. So the incidence is going up and the number is going up. So it's projected that there'd be over 111,000 sports-related injuries in 2024 in this older population. So we have to learn how to manage these patients, and better yet is how to keep them from injuring themselves. But this is a problem that's probably epidemic. Next. This brings you to probably the biggest thing next to martial arts and skiing. The rest of the year, it's pickleball that brings most of these patients. It's increased popularity. We've seen an epidemic of injuries. I know Dr. Coslick has had special interest in this. It's a fun game to play. It's competitive. You don't have to be particularly athletic to play it, but if you're really at risk for injuring yourself. So when these patients come to your office with a pickleball injury, you've got a captive audience. And the thing you have to explain to them, this is not a recreation. This is a sport. and they need to be in or get in shape, and that includes strength, mobility, proprioception, and balance training if you want to play pickleball. You need to warm up. A lot of these people come off their scooters and they kind of show up with their rackets and they start playing. They don't warm up at all, and I think that increases their risk for tendon injury. A lot of these people don't play in court shoes. They play in their running shoes. They play whatever shoes they walk in. You need court shoes to play. Probably the thing that I see that's so frustrating is that they don't play at their skill level. They go to the court and they got some either younger people or some very accomplished older athletes out there, and they try to play with them. And that certainly they try to keep up with them, and you wouldn't do that in any other sport, whether it be football or soccer or whatever. So play at your skill level, and then after you play, you really again need some time to cool down, recover, and stretch after play, and that will certainly make you feel better for the next outing. Next. All right, Alexis, I'm going to let you kind of run through the CAQ so I get my voice back, and I'm going to stick around in case there's some questions about each of these questions.
All right. So our first question is a 65-year-old female with 4 months of left knee pain. The pain is worse with walking and when she first stands up. She's retired but enjoys being active, playing pickleball, golf, and participating in yoga. She's had to decrease these activities, which is very upsetting to her. Her physical exam reveals mild effusion, tenderness over the medial joint line. Her range of motion is still fairly good, 0 to 130 degrees, and she does get some medial joint line pain with movement. Otherwise, her ligament exam is normal. So the question is, what is the next best step for the patient? Should you do a steroid injection for her? Should you give her some NSAIDs and send her to physical therapy? Should you do viscosupplementation, refer her over to someone like Dr. Wilckens and do arthroscopy, or send her for a total joint replacement? So I can go back to the question if you just want to review exactly what we're asking, but what is the next best step to do for this patient? I don't think I'll be able to see the chat. If you want to unmute yourself to answer, otherwise, if you want to just try to answer it to yourself, and then I'll go over the answer. All right, so it looks like most people said B, which is great. So that is the correct answer. So in this patient, she had some mild osteoarthritis, some meniscus tearing, likely degenerative in nature, and her pain was consistent with the meniscus tearing and the arthritis on that medial aspect of the knee. She didn't mention any mechanical symptoms, so a lot of times the first line for this patient would be doing things like physical therapy, maybe a brace. She could do some anti-inflammatories, modify her activity, and then the injections, surgical consult would probably come further down the line if she's not improving with some of these first line treatments. All right.
Alexis, I would add that surprisingly, a lot of these patients get better. I mean, tearing the meniscus is painful. They can't walk for a couple of days. They want surgery right away. But sometimes by the time they get in to see the surgeon, they actually feel pretty good. So I would hold to your guns, tap the brakes. Over half will get better. There are plenty of other things they can do to maintain their fitness besides running or playing pickleball. So they don't have to shut down to rest that knee. So I think you really want to push that conservative management up front. And a lot of them will respond to some physical therapy. They've not had a good evaluation and be able to balance their core. The kinetic chain would be very helpful. And you kind of explain those things to them why they're and if they do need surgery, their recovery is quicker. So I mean, those are all some tactics I've shared with my patients to try to put off the surgery as long as I can.
Number 2, so what are the critical components of an exercise prescription for an aging athlete? So a lot of these are different combinations of the same things, but strength training, aerobic exercise, nutrition counseling. B, weight loss and aerobic exercise. C, balance training, strength training, and weight loss. And D, nutrition counseling, balance training, strength training, aerobic exercise, and stretching. So hopefully the poll will work and I will not go too quick and we can see what everyone's results are. All right. Looks like 92% said D, which is the correct answer. Um, so these are the recommendations. You want to have 150 minutes per week of moderate exercise, or that can be 75 minutes of vigorous exercise per week. Strength training at least 2 days per week, hopefully more, as Dr. Wilckens mentioned before. And you want to make sure to target all of the major muscle groups. Balance training can be anything from Tai Chi, yoga, just even practicing standing on one foot, walking backwards, anything that's going to challenge your balance. Nutrition counseling, so not just weight loss. Some of these athletes may already be at a healthy weight, but especially stressing the importance of protein. Following diets such as the DASH diet or Mediterranean diet are generally healthy and more of an anti-inflammatory diet, which may help with just nutrition in general and maybe some joint pain as well. And it is important to be at a healthy weight, not necessarily weight loss. And so that's where the stress needs to be for the weight. And then we know tendons can become stiffer with age, joints lose range of motion with age and arthritis. So stretching is really important to maintain your range of motion and improve range of motion at the joints.
Again, I think what you'll see in your office, particularly in the older gentlemen, they put on 20, 30 pounds, and they just go back to their high school mentality that they used to go out for a run when they got out of shape or they got a couple extra pounds. So running to lose weight is probably not the best answer, even though that's what they think should be done. So it really behooves you to kind of spend some time and tell them why that's probably not a great way to lose weight safely.
So here you have a 52-year-old male with 3 months of right shoulder pain. He enjoys swimming recreational and completes approximately 3 kilometers in the pool 2 to 3 times per week. Pain is over his superior lateral shoulder and occurs during and after swimming. He has tried NSAIDs with minimal improvement. He wants to keep swimming, but the pain is limiting his ability to continue. So on exam, he has a forward posture with some mild deltoid atrophy. His Hawkins and Neers tests are positive. There is some scapular dyskinesis, and he has a negative Speeds and Yergeson's test. His MRI did show mild supraspinatus tendinopathy. So you diagnose him with swimmer's shoulder. And what do you recommend for his rehab protocol here? So you can improve rotator cuff strength and scapular stabilization, tell him he should stop swimming, work on Codman's exercises, or sleeper stretch. All right, 100%. Nice. So A is the correct answer. So rehab really focusing on that rotator cuff, the strength, stabilizing the scapula to improve mechanics and motion. He's not frozen, so your range of motion can be more aggressive than Codman exercises, which is like your pendulum exercises. He's also probably going to be tighter in his anterior shoulder. So you want to focus stretching, I mean, diffusely at the shoulder, but more so at the anterior capsule and anterior structures, whereas the sleeper stretch is really going to focus more on your posterior capsule. And swimming may have to be temporarily discontinued, but maybe he can keep swimming with some type of modification and just adding in the rehab.
Yeah, I agree with that completely. Alexis said sometimes you can just use a kickboard. They can or use something so you just put their shoulders at rest and they can still get in the pool and work up the heart rate.
All right, and then I think we have just one more here. And I would say this is a good CAQ question and probably a common clinic question too, but you have a 45-year-old runner. She comes to your clinic with mild knee pain. Her PCP ordered x-rays and an MRI that showed mild OA and medial meniscus tearing. She is concerned that she needs to stop running or she is going to further tear the meniscus and make the arthritis worse. She is also inquiring about having surgery and is very concerned because her mom recently underwent a total knee arthroplasty. The question for her is, what do you recommend and counsel her on? So stop running and switch to biking to prevent worsening her knee OA and meniscus tearing, since recreational running is harmful for cartilage. Focus on strengthening instead of aerobic activity now that she's in her 40s and needs to maintain her muscle mass. You tell her that studies show that elite runners and sedentary adults have lower rates of arthritis than recreational runners. Or you tell her that it is safe to continue running, but consider a variety of activities with rest and recovery days and modification to her running mileage. Okay, so hopefully people heard what I said, but take a quick glance at the answers here as well, and then answer the poll, and we'll go over this one. All right, 100% said D, and that is great. It is safe for her to keep running. She may want to consider a variety of different activities, the rest and recovery days, maybe modifying her mileage. So this could look like adding strength days on alternate days from running days, so that she's getting change of activity. The other thing to note is that for hip and knee osteoarthritis, it's actually the lowest in recreational runners. Sedentary individuals have higher rates of arthritis than runners. There is a higher level in elite or professional runners, but it's unsure if this is actually due to their volume of running, or maybe there's some other predisposing factor. So it's not completely clear, but studies have shown that recreational runners do not necessarily have higher rates of arthritis than those who are sedentary.
And I would add to that, Alexis, that when these runners come into your office, that they don't want to hear they can't run again. That's a kiss of death for them. So if you give them an alternative, they usually take it. And then we can also share with them as they become stronger, they actually become better runners, and they'll actually run with less pain or less discomfort. So I think there's a real value added to mixing up the program and alternating days with something strength training or some other type of aerobic activity.
And that's it. So I will stop sharing my screen. That way I can look at the chat. If anyone has any questions for Dr. Wilckens, either about something in his presentation, he has a huge wealth of clinical knowledge too. So I think he's a great resource for asking any questions that you might have about this patient population. All right, so Dr. Wilckens, we do have a question in the chat from Dr. Imam. He says, thanks for the excellent presentation. Are there any specific considerations for post-ACL reconstruction rehab in the older athlete compared to the younger athlete?
Again, I'm probably a contrary surgeon because I use bone tendon bone. I like the cortical fixation, so I think I can accelerate the rehab a little bit. These people typically have other things going on in life. They may be still working. They may be traveling. I think allowing them to be a little more active. I think a lot of our younger athletes have trainers and they get pampered by parents and stuff. A lot of these older patients may be by themselves, or they may have an elderly spouse that's trying to take care of them. But I think with the cortical fixation and the bone healing, I've liked the bone tendon bone, but people have gotten excellent results with allograft. I think they probably don't have the strength to go up and down stairs. I mean, you may want to put them on the first floor. Sometimes you use a walker instead of crutches. But they do a pretty good job. I would probably get them on a bicycle sooner. As far as their exercise, and I probably would not push the running until much later, maybe 4 or 5 months instead of 3 or 4 months. Um, but I've been pretty impressed on how quickly they recover. I don't know, it's because they've had life experiences, but they tend to take less narcotics. Um, one thing I will take up in this population, I forgot to mention, is that they non-steroidal sometimes they don't have dyspepsia with that. Sometimes they end up with a GI bleed. It's the first symptoms of a non-steroidal that's not tolerated. So I try to minimize non-steroidals in this population and just use them judiciously in the acute phase. Um, but they do well. They do very well. Except they probably do again. I think they probably keep on the first floor, use a walker, and probably delay running a little bit, and probably use a bike more than some of the other traditional things. I don't know. I don't. I would defer to my PT colleagues whether they are candidates for BFR. Some of the other newer things that we're using for our athletes that are trying to get back to a sport. I don't know how that is tolerated in that population, but certainly I would. I don't know. I don't think it's contraindicated. I just haven't used it.
Thank you. That's very helpful to hear. Doesn't look like it. So thank you, Dr. Wilckens, very much for sharing your knowledge with us and going over this important topic, since this is a very common patient population we probably all will see in clinic.
Guaranteed.
Thank you.
They
Bye.
usually have insurance too. So
Yeah. All right. Have a good night. Bye.
good night.